This is what it looks like, yeah. About 30, well, out of 90, about maybe 30.
This is what happens.
It doesn't mean 60 is dead.
Oh, gotcha.
It was nice to see the ones that were there. The ones that were there and the ones that came were the ones that were more interested and more robust anyway. So it was fun.
Classmates.
Because it's already.
I don't anymore.
I never opened them, but they are a little intriguing.
So,
Do you recognize the names of the people? Or?
Well, they keep everything hidden. Like you pay money.
Oh, I see. Oh, I know what
They
you're
just
talking about.
entice you, like, oh, see the these classmates, so I wouldn't remember.
I was thinking of trying to go up.
So Dr. Ayers, Senior, are you going to Houston?
No, I didn't. I'm bad.
Not bad.
Sorry, Lynn. I'm just staying home. I know I'm going to go to Sun Valley. I might have to be on Man Maven, though. I just got to get, at least I got to get 2 or 3 days skiing in, or I feel like I haven't done anything anymore. So.
It's got to be those 2 or 3 days.
Yeah. I had to wait till March because my surgery on my shoulder, so I had to.
it's okay. It's okay. We're going to do it.
Not have surgery.
Because we've got to speak
Back in October. But,
So,
Come on now, sign your life away.
summer. But no, I'm done with surgery.
Sign your life away.
So weak.
Show up on some kind of list
is there
somewhere.
something that like you
I'm doing what
Yeah, but no one cares as long as they're not IRS.
I know that Kobe Bryant is for a good road paid to come. They said it'd be 8 months for him.
Yeah, his career is.
On the way.
It's amazing that he came back from the other injuries.
I agree.
Playing well.
Pal, have you gotten up skiing yet? You did? Where at? It was open. Is it open now?
Actually, it's the only thing open right now. Nothing's passed.
You have a condo at Alpha? Yeah.
The Tier 2 had snow. I don't know what happened to it now, but this last weekend it just went to Tier 3. That's the little one at the bottom.
Even says been closing parking lots till they can scoop all the snow out of them and put them in a truck and take it up on the hill.
Is that right? Is it open?
It's all open, but it's just crap. I mean, it's not even spring skiing, it's just rocks and sticks.
Do you show up because you're on ski patrol?
Good morning.
Yeah, I show up and go out and take a few runs and get depressed and then come back in.
Have you gone up to Whistler this year yet?
It's just as bad. The bottom's all roped off. There's only one way into the village on the mountain. Everything else is just dirt. It's really amazing.
Now you have the timeshare there, right?
Or can you send it?
Looked like Central Valley.
Yeah, in Utah had some snow too. It was 72 degrees there this weekend. In Salt Lake. Yeah, a little bit warm.
You're not done.
No. We'll try it.
Take a trip to Colorado.
No, that's very cool.
We got all our runs open, but
Ski registration.
What did you just do?
Put it in here?
Yeah, but they started charging now.
Whatever reason.
About 1100 bucks.
I've never done anything in Houston. That was an excuse to go.
Yeah, I've been to Houston.
I remember we went to San Antonio and we drove over to the coast.
Yeah.
We saw the movie.
Right, that's right. I was just
You were in the village, so we went down to Corley. No. Rented a car, drove over to see the whooping cranes, and that was a nice park, and there was peccary out there. But where were we
I'm not sure they know what they're measuring.
Mostly because I was
And they're measuring
John
I'm not sure they know what they're measuring.
They're cool.
Actually, here's the answer. I just have the information.
Where did you see this? It was coming down the
You get an accurate number. How long is that waiting room?
Okay, wow.
It was like a year early. I went to colonoscopy.
That reminds me.
Not working.
I know. I'll have this on.
Quality. To get treated.
I enjoy it. Majority of us are more than the resident. No, it's even worse than that.
I wouldn't do it. I thought I would. 2 days before you make the session, you have 10 other modules.
Yeah.
10 meaningless modules, the kind of thing where you click through, take a quiz, fail, and
It's not very sensitive.
It was on electronic medical record quiz.
The amount of money they could get. They're back to zero.
I've been my nightmare. It's probably cool, but now we're down to everything.
Well, you have to into it anyway.
Why retire for
them to
Whether it's augmented or not.
Medicare.
No, I'm holding out. You know,
But in your system, it'll work out just like mental health. Have any follow-up in any years? Yeah.
we had a good day.
they are Metatron.
Well, that's getting fuzzier and fuzzier.
Here, if you want to take a picture, take a picture of
Clear on the
79.
This over here?
Did you guys get them all in the contract?
You're welcome.
Got something.
You probably don't care.
You got to learn to set it. Process.
It's overstated.
Let's go ahead and get started this morning. For those you see and me, the word of the day is Davis. You did your training at Davis. So Dan is going to talk today on, he's going to tell me here, but I think new biologics, hopefully, basically an attempt to catch up with the rheumatologists and have enough, be modern.
Good morning, everybody. So, I was asked to give this talk about kind of updating on the new kind of biologics that are going to be upcoming, and I try to focus this talk more on the stuff that's most likely within the next 5 years. I have no disclosures to make. A brief little outline. Anytime I like to give a talk, I like to talk a little bit about the past before I move on to the future. So, a little brief history of asthma. And then we'll talk about the new biological agents as well as some thoughts about asthma phenotyping. Objectives, you have it there. All right, so brief history on asthma. The treatment of allergic disease and asthma has a long history dating back all the way to ancient Egypt, probably even before that. There's scripts and things written back like 2000 BC. So the first time the medical term for asthma was in Hippocrates' Corpus Hippocraticum, and it was for any kind of description of any sort of breathing with difficulty. And that was kind of the blanket all term, was asthma. And the mainstay of treatment for at the time was burning of herbs for inhalation. And this was pretty much the standard of care all the way up into like the 19th century, where they kind of the first big kind of paper about asthma treatment was by Dr. Salter on asthma and its pathology and treatment. And the mainstay of treatment was the smoking of Datura stramonium, or gypsum weed. Stramonium is in the same family as deadly nightshade, which, including many chemicals, had atropine in it. And according to Salter, he thought it was more of a preventative than a cure, so it was more of a controller agent. And he advocated smoking a pipe each night before bed in order to keep the disease at bay. Fast forward a little bit to the early 20th century, Dr. Osler, who was one of the founders of Johns Hopkins, kind of outlined the state-of-the-art treatment at the time, which was the use of antispasmodics with belladonna, also has atropine, henbane, stramonium, and lobelia, and they can be used in the form of cigarettes. And that there were many different types of cigarettes that were filled, and then filling the room with fumes of this paper before it was a way to ward off a nocturnal attack. And so there were many types of asthma cigarettes that were marketed starting in the 1850s and all the way into the 20th century. And Dr. Batty's asthma cigarettes, I want to point out this, not recommended for children under 6. So 7-year-old could be smoking up. But we can't leave out the little children, so they had asthma powder. And we have a funnel here, so we have a little bit of a max spacer to be given to kids. This was stuff that was still used in the 40s and 50s. And in fact, in the 60s, in JAMA, there was this doctor lamenting the fact that she was having a hard time finding her asthma cigarettes that she would use for herself as well as for her patients. And she concluded her article that several local drugstores stocked these cigarettes for me and my patients, and she, at the very end, said, "Light up and live." The death of asthma cigarettes, so what really kind of prompted the kind of out-phasing of this was in the 40s and 50s with the introduction of inhalers and more effective medications like epinephrine, etc. Can anybody guess when the last paper to talk about asthma cigarettes was published? 1980 was in the Clinical Pharmacology of Herbal Cigarettes. It was titled a paper in the British Journal of Clinical Pharmacology, which you can still get. It was actually a nice paper. It actually showed clinical efficacy of it and showed anticholinergic effects of the asthma cigarettes. One of the reasons they published this paper was that there was a bunch of poisonings in Britain at the time with kids eating the asthma cigarettes, and as well as abuse potential for it. People were using this as a way to get high as well as a hallucinogen, and that's what eventually led to its ban in 1985. It's when this stuff was banned. All right, so enough history. So what's next in asthma treatment? So with the start of the 21st century, we saw the approval of the first targeted therapy directed at the underlying mechanism of allergic disease, omalizumab. And the approval of omalizumab was well over a decade ago. It was 2003. So it's been 12 years. So what is next? So these are the targets that are likely going to be the stuff we're going to be talking about over the next 5 years that I'll be spending much more time in detail about each one. IL-5, IL-4, and IL-13, IL-13 inhibitors, and then one of the newest ones, and a very promising one, with the paper just recently published, was TSLP. And I think this is going to be a very important thing to talk about. And we'll discuss each of these mechanisms in some detail. So this very busy slide, let me orient you to this. So we have airway epithelium here, and then we have our kind of the mainstay or central role player here, our Th2. And these are all the different drugs that are going to be blocking these pathways. And some of them which are in various states of readiness, but we'll be talking about a couple or so, I think the 6 or 7, they're likely to be coming. And we'll get back to this slide at the end with a little bit more information. Okay, so IL-5. IL-5 is produced by the Th2 cells, and they, as well as eosinophils, basophils, and mast cells. There is a significant amount that circulates in circulation and plays a key role in eosinophil proliferation and survival. And IL-5 is largely specific to the eosinophils. And we can see that it works through both PI3K, NF-kappa B, as well as the STAT pathways, depending on the cell line. So the current targeted therapies for anti-IL-5, the first one is mepolizumab, which is a humanized monoclonal IgG1 antibody specifically against IL-5 that can be given IV or subcutaneously. and it's administered Q4 weeks. And we'll talk about that one in some great detail. Recelizumab, which is also another humanized monoclonal IgG4 for IL-5, and then an IL-5 receptor blocker, benralizumab. So mepolizumab, we've talked about quite a bit in the past because at the U we have it as an available drug for eosinophilia, but let's talk about it in terms of asthma. So this was published in the New England Journal this year, and it was the mepolizumab treatment in patients with severe eosinophilic asthma. It was a double-blinded, double-dummy phase 3 placebo-controlled trial. 802 patients were enrolled, and several didn't meet the criteria, and ultimately 580 underwent randomization. And then about 190 in each group with a pretty decent completion rate. So that usually tells you something's working. So the main characteristics, so these were definitely in the adult range. So the mean age was in their 50s with kind of equal distribution of males to females. And FEV1, so these were all pretty severe asthmatics with the 62% FEV1 predicted as kind of the 60% kind of being the average. And some of which have had asthma-related intubations, so in the past. So here is looking at asthma exacerbations relative to placebo, both to subcutaneous as well as to intravenous mepolizumab. And we can see that there is a significant difference in the cumulative number of asthma exacerbations versus the treatment groups. In terms of adverse events, for the most part, there's not really much significant difference than placebo. For its most difference between placebo was the injection site reaction, which was more so in the subcutaneous than in the IV forms. But for the most part, it's about on par with the placebo control. So it seemed to be a pretty safe medication with no fatalities. One fatality in the placebo group, though. So the other IL-5 biologics, recelizumab, has completed. That was a phase 3 trial, by the way. So
how close that is to approval?
We'll talk about that at the end. So we'll talk about each one of these and how far they are. But recelizumab completed a phase 3 also and found to have significant improvement of lung function, asthma control. Benralizumab just completed a phase 2b, which significant reduction in their asthma exacerbation rates. Okay. So the next area will be Interleukin 4 and IL-13. IL-4 and IL-13 share most of the similar effects, except that IL-4 causes more differentiating of the Th cells to specifically Th2. The principal cellular source is Th2 lymphocytes as well as mast cells, and they act locally in the airway and not detected systemically. IL-13 administered reproduces most signs of asthma and has been termed the central mediator of asthma. The effects of IL-4 and IL-13 causes mast cell proliferation and activation, also induces the isotype switching for IgM to IgE, as well as eosinophilic adhesion to vascular epithelium, and increased epithelium permeability, goblet cell differentiation, as well as growth, and fibroblast activation and collagen synthesis, increased smooth muscle contractility. So we can see here that both IL-4 receptors and IL-13 receptors act, which are similar, act through the STAT6 pathway in the Th2 cells, and eventually causing their effect. So what do we have that targets this? So we have a couple different agents. Lebrikizumab, which is against IL-13, and tralokinumab. We need new names for these things. Fully immunized to IL-13, and then the receptor blocker that both blocks IL-4 and IL-13, Dupilumab, which has fully human IgG4 against IL-4 receptors. So for IL-13, the L drug, humanized antibodies in the study population of 219 with symptomatic asthma, who still had asthma despite high dose inhaled corticosteroids, were randomized to subcutaneous L drug versus placebo, and baseline remained constant, and then were stratified based on their what they call the Th2 signature, and we'll talk more about the phenotyping for Th2 in a little bit, as well as their Ig levels and their blood eosinophils. And then they also had this kind of novel way of differentiating this group with something called periostin, which is a kind of blood marker that we'll talk about a little bit more at the end, with the primary endpoint being change in FEV1. And from here we can see that, and this is again monthly therapy, and we can see that here is the change in FEV with a 9.8 versus 4.3 with a significant difference, as well as 14 versus 5.8% with a significant difference. So this is the total cohort, but then differentiate between the periostin and the low periostin group, we can see that they were able to kind of customize this therapy. So the periostin group seems the one to be the most benefit. And we'll, like I said, we'll talk more about like kind of figuring out which patients are going to be the most beneficial agent to these medications. And I think that's one of the reasons why mepolizumab had such a difficult course getting accepted, was because they didn't pick the right group. So especially, it's been around almost as long as omalizumab, but it hasn't been approved, mainly because I think they picked the wrong groups when they first tried to do their clinical trials. So in a little different way, we can see looking at the high periostin versus the two high periostin groups with placebo versus drug. And we can see the dramatic decrease in their exacerbations. So Dupilumab is the kind of both IL-13 and IL-4 receptor blocker, so because it targets receptor. And this was also in a group of kind of poorly controlled asthma despite ICS. And it was a subcutaneous therapy weekly versus placebo. And they stratified it between the high and low eosinophil groups. And they also looked at ICS tapering to see the effect of this drug. Okay. Very busy slide, I'm sorry, but you can see the number of exacerbations as a primary endpoint, and we can see here this is placebo, this is Dupilumab, and we can see that there was a significant reduction in the number of exacerbations, as well as looking at cumulative exacerbations, and this is the phase where they kind of tapered off their controller medication, and we can see that with the Dupilumab group it basically stayed flat, while as the placebo control we could see that there was significant increase in their background. And then also here on the bottom, so we see a nocturnal awakening, and we can also see that there was a significant difference between the two groups after they tapered off the steroids.
You skipped over the FEV1. Did that get better as well?
Oh yes, so the FEV1 also kind of improved as well and did not really change. Both. They also have done kind of preliminary studies on atopic dermatitis. This was kind of like a preliminary early phase trial. And they did a placebo control with varying doses of subcutaneous Dupilumab. And this was looking at the pruritus numerical rating score. And we can see the 3 different kind of doses of Dupilumab. This was weekly subcutaneous. Placebo. And then, let's see, 300, 75, and 150. And we saw that there was a significant difference in the treated groups, and pretty quickly. This is only in 30 days. So in just 30 days, there was a significant decrease, as well as they also looked at kind of the body surface area, the amount of kind of eczema that they had on their body. That also diminished significantly as well. They also did a more long-term study. So the dose study was done in the United States. The bottom study was done in Europe. And this was a much longer term study looking just at 300 milligrams Q weekly. And we could see that there was significant improvement of their atopic dermatitis going forward. Much improved compared to placebo. And these were people who were still on kind of topical corticosteroid therapy.
Was that in children or adults?
Those were adults. Unfortunately, most of these things are all going to be in adults. Yeah. Usually with kids, we're always about 10 years behind. So the summary here of IL-4 and IL-13 inhibition. So these seem to be the most effective in patients with active Th2 inflammation. And IL-13 antibodies appear to have a beneficial effect on pulmonary function. And they seem to have much better control of in terms of exacerbation, and as well as getting off kind of systemic as well as inhaled corticosteroid therapies. The next area I want to talk about is the Thymic stromal lymphopoietin kind of pathway. The principal cells.
Dan, before I get on that, the local company Immunologic, before they were bought out by Amgen, developed a soluble IL-4 receptor antagonist.
Mm-hmm.
But it wasn't, clinical trials didn't show any benefit in asthmatics. They had a similar one where they kind of provoked the exacerbations by withdrawing the steroids.
Mm-hmm.
So do you think, did they comment in any of the discussions with the combo IL-4, IL-13, whether the blocking IL-4 really adds anything to just developing the IL-13?
Well, I didn't read that specifically though, but it seems like the IL-13 is I think the biggest role player here. Yeah.
I remember those studies. I don't know if it was, again, selection of patients, like the problems with Mepolizumab. Because I remember Larry Borish did the early study on that, and it looked very promising. And then the bigger study to just as bad asthmatics without self-selection of whether they were eosinophilic is what failed. Do you recall, Bill?
Yeah, it was like an all-comer. But they did do that one where they forced the exacerbations. Just looking at exacerbation rates.
You're certainly right with Mepolizumab. The early studies failed, and it probably set the drug back 10 years until people started looking at induced sputum or other markers of eosinophilic asthmatics.
Yeah, absolutely. And so I'm going to spend at the end here talking about why that specific thing and kind of broadening our kind of diagnosis of asthma much more than the current way we're identifying asthmatics currently. So the principal source is epithelial cells and acts locally at the epithelium and involved in response to microbes as well as to allergens and has a potential role in Th2 inflammatory response. And the main effects are on dendritic cells to induce Th2 lymphocyte development as well as augment Th2 cytokine release as well as inhibit T regulatory cell functions. So here we can take a look at the kind of the various markers we've already been talking about, but the thing that kind of gets this stuff rolling is this TSLP. So once this inflammatory stimuli, whether it be allergen or microbe, attached to the epithelium, this is also skin epithelium as well, that TSLP is released and activates both the dendritic cells as well as mast cells to cause the kind of cascade of events that we've been talking about. So TSLP and allergic disease. In the mice model, keratin-specific overexpression of TSLP leads to an atopic dermatitis type phenotype. Lung overexpression of TSLP in mice resulted in severe allergic airway inflammation that mimics a lot of kind of the signs and symptoms that we associate with asthma. But interestingly enough, that crossbreeding these TSLP mice with STAT6 deficient mice or with blockade of IL-4, IL-13 block the airway disease. So Th2 cells are definitely needed for this pathway to occur. And this indicates, and it's dependent on Th2 response. So most recently, a anti-TSLP antibody looked at kind of like the allergen-induced asthmatic response. So not as a treatment for exacerbations, but more as something as a preventative agent is what they were kind of doing. And this was a kind of a preliminary phase 2 double-blind placebo-controlled in people with mild allergic asthma. And specifically, they wanted mild allergic asthma. And the primary endpoint for these was the percent decrease in FEV1. And this was measured 3 to 7 hours after allergen exposure. Secondary endpoints were eosinophils in the sputum, blood, pheno, as well as levels of Th2 cells in the blood. So the clinical demographics, very typical of an early phase study with in their 30s, predominantly men. And if you can take a look here at their FEV1, their basically FEV1 was normal, so 97, 95%. So not but they had all confirmed methacholine challenges, and they all had a response to methacholine. But interesting enough, they had on average a pretty high fractional exhaled nitric oxide, 58 versus 42, as well as a pretty decent amount of sputum eosinophils and an elevated level of blood eosinophils. These gentlemen were also, or ladies and gentlemen, were also not on any controlled medications. So they weren't on any Singulair, or they weren't on any ICS at all. Okay. So here was the study design. So they did a pre-allergen challenge, as well as doing a dose of the anti-TSLP drug. And then these were kind of monthly doses. And they did 2 challenges of allergens during the course of treatment. All right. And so here is the kind of the day minus 14. And we can see that between the 2 groups, because the treatment hadn't started, we see no significant difference in the change of FEV1. And at day 42, we can see that there was a significant difference between the 2. And that, especially at day 84, we can also see this kind of blunting of the allergic response in the treatment group. They also looked at sputum eosinophils. All right, and we can also see here that this is kind of the pre and then the treatment. And then this was the allergen exposure. And we can see, as expected in the placebo group, with the allergen exposure, we would see the eosinophils rise up. But this effect is blunted in the AMG 157 or the anti-TSLP drug, which makes sense. If you block the thing that communicates from the epithelium to the Th2 cells, you're not going to see the release of IL-5, IL-13, all those kind of homing targets to bring in the eosinophils into the area. And we can also see this occur also kind of at the kind of day 80 mark. Fractional exhaled nitric oxide also had a similar type of kind of matching with the kind of the eosinophils, which makes sense.
So that slide makes it look like there's a pretty good correlation between ENO and sputum eosinophilia. Mm-hmm. And the literature is a little mixed on whether ENO is a good surrogate marker for specifically eosinophilic.
ENO is not perfect.
Huh?
Right? Definitely, ENO is not perfect.
Okay, well, I was just wondering, in reading these papers, what's the commentary about that? How good FeNO is as a surrogate marker just for eosinophilic inflammation?
What the literature has bared out, especially in the pediatric population, that it's not a good marker for it. Like all that FeNO does is that puts more people on ICS if you base it off of that, but it doesn't actually change the outcomes for asthma or improve clinically. And that's kind of at least what we know right now. But I think it's going to be an important marker for phenotyping that I'll talk about more at the end.
I went to a recent talk, Prescott Woodruff, they've defined at UCSF this Th2 phenotype. Yeah. Because when they did bronchial biopsies, half the asthmatics had IL-13 driven genes, and that's where they found the periostin as a potential biomarker. And then he was just saying they've gone through their data and they found that exhaled nitric oxide was just as good as periostin.
That's interesting.
So, because they don't have any good commercial assays for periostin now, you have to go through Genentech to do it. But
like how did they?
Yeah, no, looking like that may be a good one. They're in the process of publishing that to compare periostin and
how they do it? Was it relative change in FeNO with like an allergen? Okay.
And they also grouped into the high. It was just like periostin, certain cutoff. Half the population was significantly above the other one, and same with the exhaled nitric oxide. There was a separation quantitatively, and I forget what the.
There's certainly confounders, there's certainly confounders to this. Like I'll talk about this a little bit more, but I did a preliminary study on just control versus asthmatics for exhaled breath condensate, and we also did FeNO in these people, and the highest FeNO that we had was in the non-asthmatic group. It was one of the kids of one of the docs that worked there, and it was like 100. And we did it like 5 times over like a month just because it was so weird, and it was pretty consistent. And the kid did not have asthma.
What do you have?
I don't know. But the kid was completely healthy, growing, beautiful boy. So there was no problem with him. But he had the highest pheno of the entire group. Even the severe asthmatics didn't have as high pheno as he did. So I don't know.
Well, I mean, in contrast to that, we do it in the office, and you've worked with me some. And certainly I find in people with atypical dyspnea and normal spirometry that a high pheno is an extremely helpful test. Most of the time, clinically, you put people on inhaled steroids, it plummets, and they get better.
Yeah, I definitely agree with you. Like, it's actually standard of care over when I was practicing in California. Like the biggest insurance company out there, Kaiser, that was the standard. Everybody would get a pheno there, and we did it at Davis too. So it surprised me that we're not doing that more actively here.
We should do it at the U.
Treatment day was day one?
Yes. Yeah.
What, is there any discussion about why you see that change in the pheno but not in the sputum eosinophils for that early period?
Oh, at the very beginning? Oh.
Yeah, from day 1 to 41.
Yeah, this one is not. You're talking about right here.
You see a change there, but you don't see that in the upper slide.
It's not significantly different, so they don't have the little asterisk. So it wasn't significantly different from placebo control. All right. So this is definitely preliminary for this kind of proof of concept trial. This anti-TSLP successfully attenuated allergen-induced bronchoconstriction and then known indexes of airway inflammation, both pheno as well as sputum eosinophils. And it's a good first step, but more certainly needs to be done. And the other interesting thing is that ITS do the same thing. Inhaled corticosteroids do exactly the same thing, but I'm sure it would be a lot cheaper than TSLP. So TSLP, I think, it definitely has potential, but not in this regards, because it's showing good mechanism, but I don't think it would be a cost-effective way to kind of prevent kind of airway-based, like mild allergy type stuff. So we probably have to see it in the more severe asthmatics before I make this as a kind of go-to drug. So back to this slide that we talked about at the beginning, we can kind of see.
On the TSLP,
yeah,
those data were done with an Amgen compound, and they've just entered a big clinical study in cat immunotherapy.
Yes.
Are you going to talk about that? Or?
No.
Because they're going to.
Steve Tillis is running that locally, called a catnip study.
Yeah, it's one of the first ways to kind of a new approach to induce tolerance.
Yeah.
Because if you knock out one of these key Th2 regulatory molecules at the same time you're inducing our traditional kind of sub-Q immunotherapy, you've got the chance of actually deleting key memory cells.
Good idea. And I think it might be helpful, like in drug sensitivity too, like drug hypersensitivity type stuff as well, as a way to improve tolerance. So there's definitely a lot of potential for this drug, and it kind of stopping at the very beginning. So we can see that we've kind of all danced around this kind of mainstay. So blocking the signal from getting to the Th2 receptor, so with the blockade of TSLP, as well as kind of blockade of the other effector molecules, so IL-5, as well as IL-13, as well as IL-4 and IL-13 as well. So we can see that we're kind of dancing around this cell as kind of the biggest, most important thing. So when are they coming? So when are these guys coming down the pipe? So Mepolizumab has completed their phase 3 trial, and they filed their new drug application on November 2014. Generally 9 months post new drug application, and it's probably likely going to be approved. So August this year, most likely that we'll have Mepolizumab as a possible treatment. Resolizumab also completed their phase 3.
Indication? Asthma or
Asthma.
hypereosinophilic?
Asthma, as asthma, yeah. So Resolizumab.
Hypereosinophilic is a compassionate use one, so that won't be part of the label.
Yeah, we have at least
It's
one
available
person.
now, but it wouldn't be.
But it'll be less of a headache.
Filed for that indication.
No.
And it'll be less of a headache for Drew, I think.
They did file for it and reject it by the FDA.
How could they reject it? So obviously effective. You don't know the answer.
It's a very good question. So Resolizumab also completed their phase 3, and next month is kind of the projected when they're going to put their new drug application in. So maybe late this year or early next year. Benralizumab, the phase 3 is ongoing currently, and so not likely till next year for the new drug in maybe 2017. Lebrikizumab, IL-13 blocker, phase 3, but had issues, now back to phase 2B. So not likely till 2017 at the earliest, so who knows on that one. The other IL-13 has, as well as the Dupilumab, both have phase 3s that are ongoing right now, and likely completed.
Do you know what issues there were that bumped it back to 2B?
It was just production, something about production issues. I didn't get a lot of detail.
Yeah, there was a contaminant.
Yeah, contaminant,
People
yeah.
were getting severe site reactions and some myositis and some CPK elevation. That's a Genentech.
Yes.
And do you know who owns each of these?
I do. I didn't put it in there.
Just here, I know Mepolizumab, GSK.
Yeah, I didn't put all the company names. And then, except for Amgen, so sorry. But phase 2, very promising, and who knows when all this stuff's going to come out, but probably within the next 5 years. So what is treatment for asthma going to look like in 2020? So we'll have all these tools to treat asthma, and these are very important steps over the coming years. But I think a very critical thing is which patients will benefit from which therapies. You could even have combo therapies. So you might benefit from IL-13 and a TSLP, or an IL-5 and a TSLP, or one or the other. So I think phenotyping is going to be, for asthma, is going to be a very important thing. Much like in oncology, where like leukemia used to be based on like somebody looking through a microscope. Now it's all genetics. And so I think phenotyping asthma is going to be a very important thing. Otherwise, I think what's going to happen is that we're going to be basing it on what drug companies approve, what insurance companies approve for which indication, rather than what's best for the patient. And I think us coming up with new types of way of diagnosing asthma, as well as the specific type of asthma, is going to be particularly key.
Off that slide? You know what you left off that slide? Nick's coming out of retirement.
All right, so what is asthma phenotyping? And this is to expand and identify specific phenotypes of asthma and to use this knowledge to customize therapy. So currently, our basis of asthma diagnosis and our descriptive terms for it is the prevalence of symptoms, whether it's mild to persistent, and then how much drug or inhaled corticosteroids from mild to all the way to severe. And so this kind of moves away. The first step to this has been like kind of the Th2 asthma, and so identifying Th2, but still really that's still allergic asthma. We need to move well beyond just Th2. I think that's a good first step, but it's certainly limited in our scope. And in fact, you know, we're talking about Th2, but there's a whole other type of asthmatics who are non-allergic. So I would say 50% of asthmatics don't fit this category, and none of these drugs won't work for them. So it'd be nice to know which ones we can put in these kind of Th2 kind of phenotype. And so the possible avenues to accomplish this is numerous. So exhaled breath testing, we do that, and as well as sputum testing, as well as blood tests. So our current exhaled breath testing is somewhat utilized with exhaled nitric oxide or FeNO. There's numerous confounders to FeNO. Age, gender, height, ethnicity, genetics, allergy sensitization, how much inhaled steroid that they're on, season, time of the year, environmental pollution, as well as here I found out that there's insurance coverage issues that in this state that FeNO is not necessarily covered. And I mentioned this earlier that by a study done in National Jewish found that in pediatric population, FeNO didn't improve asthma control, it just led to increased use of inhaled corticosteroids. All right, sputum testing has potential for identifying cell types in sputum, either eosinophils versus neutrophils versus mixed. There's several issues, including variability of sputum. All right, you could have concentration issues because of contamination from the mouth. And so you don't know if it's really high versus with a very concentrated sputum, or if it's a little bit lower because it's diluted by mouth secretions or by other airway secretions. So it's definitely not a perfect marker. And then blood testing. So currently eosinophils are used to a variable degree, and we talked about the recent marker periostin was shown to be beneficial and predictive of response to IL-4 and IL-13 pathway blockade. But definitely more data will be needed with this, and we need to have more study for this. What I think is going to be kind of the future of asthma phenotyping is something that we need to have that's easy to collect and something that we could do in the office, much like pheno. And I think exhaled breath, as well as exhaled breath condensate, is going to be, I think, the future for this. I did some preliminary studies as a resident where we looked at specifically exhaled breath condensate for asthmatics versus non-asthmatics, as well as, and we used a type of mass spectrometry to detect this, which is the same type of machine that they use at the airport to measure like bomb detection material. So, and it's about the size of a briefcase, and it's not too terribly expensive. I think it's about $10,000 for one of these machines, and it can detect down to the picomolar concentration of materials, much like it does in bomb material. And we were able to just, because we had so little money and it was such a preliminary study, just put people's and we blinded ourselves with COPD versus asthma. This was in adults. And just shot in the machine, and we looked at the profiles and said, all right, we took 5 known COPD eaters, no asthma, 5 asthmatics, put them in the machine and looked at the profile of their kind of like, of their exhaled breath. And we were able, 95% of the time, predict the COPD eaters from the asthmatics based on just their kind of peak profile. And that's blinded. That's without having a library or identifying what peaks we're looking at. And we are also doing preliminary studies in pediatrics, and we had similar type of things.
What were you measuring?
Like I said, this was just peaks, random peaks, so we don't know. So and we ran out of money. So if somebody wants to give me money, because I had lots and lots of ideas to make this thing and develop, because we need to develop a library and to go for specific type peaks.
Did you measure that after treatment too? Did the peaks change tremendously?
Yes.
But you still don't know what they were.
We still don't know what they were because we didn't have a library. So that was going to be the next step. So we wanted to do a proof of concept. Proof of concept worked, and then we ran out of money. So it's very easy to collect. There's actually commercial available tubes that you just stick in the freezer, and and like 5 puffs into a collection tube, and this has been validated down to like 1-year-olds. Just put it over their mouth, and they just breathe a couple of times, and you can collect enough to be able to do this. Like I said, the instrumentation is there. The sensitivity is there. I just need money, and I just need
Somebody
time.
must have done the studies to know what the peaks are, though, right?
Not for this machine. So this was a new technique. So what had previously been done had been looking at ELISAs and traditional mass spec, which requires the ELISAs unfortunately aren't sensitive enough. They can't get down to that super low level, and you're only going to be able, even with multiplexing, you're only going to be able to do a certain number. But with this type of device, you're able to do the same type of thing you could do with a mass spec, except you don't need if a TSA employee can do it, anybody can do it. So I think we could definitely have, and this is a machine we could definitely do in the office.
Detect people that have guns in the airport.
Detect bomb, because like if you look at all they do is swipe your bag and stick it in the machine. That's all they do. They were able to detect bombs. So, but so this is currently many years away and lots of money away. But I think this is definitely a potential that would be very helpful for us in the future. And I just talked about the Th2 ones. There are lots of other potential here there's prostaglandin pathways and other pathways, and new ones I'm sure as we go forward over the next decade or so. So what 2025, 2030 brings us is going to be even more complicated. And I think somebody with moderate persistent asthma is not going to be good enough. We need to have a much better way of distinguishing these types of asthmatics from each other. So conclusions. So like I said, within the next 5 years, there will be 5 to 7 new biological agents for the treatment of asthma as well as atopic dermatitis. And asthma phenotyping is in the beginning stages, but very important for the new biologics in the treatment of asthma.
So, you made the point that about 50% of people don't seem to be Th2. That's what we used to call, I think, in the old days, intrinsic asthma. They make a skin test or adult onset non-allergic asthma. But there was pretty credible literature from Steve Durham and Barry Kay a number of years ago saying that they have local Th2 disease and local IgE production in their lungs. You just don't measure it systemically. The same notion is true of what we might call non-allergic eosinophilic rhinitis. I'm just curious your thoughts on that, that it's not correct to not label it a Th2 disease,
Yeah.
it's just not a systemic Th2 disease.
Certainly, and I think that's why I think exhaled breath is going to be such an important, to really capture what's going on in the lungs. And so I talk about condensant, but there's also a lot of great studies about, and the amount of studies that have gone up over the last 30 years on this stuff is enormous. There's also people just with electric noses and looking at electronic noses and looking at exhaled breath. So not condensant, but actually just the breath that you breathe out and measuring chemicals there as well. So, with all these things, we can actually really find out without doing bronchoscopy on somebody. Although bronchoscopy has problems, I'll talk about that in a second. But without even doing bronchoscopy on somebody, we can find out what type of inflammation is going on in your lungs. And I think very well that might be the case, but we don't have those type of that capability easily. And I think that exhaled breath is good. But with bronchoscopy, I want to mention that briefly, is that one of the issues, that's not even a gold standard. So if you go down with a tube and spray some fluid and suck out some cells, you have a major dilution problem there. And so you could have had inflammation, you could have slight levels of elevated of certain cytokines, certain interleukin markers, but you would never know because you just diluted it with a variable amount. And every time somebody goes down, they're not using the same amount of fluid as they kind of spray their scope as they go down. So this stuff is going to get diluted. You're not going to have a good sensitivity to it. So even going down with the scope is not going to be good enough. Yeah, Bill.
Well, just the ECSF data would be different for Barry Kay's though, because for local Th2, if there was this site there that UCSF group did bronchial biopsies and didn't show the IL-13 signaling in the alpha tissues. I mean, that may not reflect the peripheral one, but those people also didn't respond to the anti-4 IL-13, so if they were like a local Th2 group of cells, you'd think those groups would respond to the intervention too, unless the drug didn't get there, I guess.
Well, all the more need for phenotyping that there are some in each of these categories.
Yeah, another approach would be to look in like another potential biomarker in the periphery would be microRNAs. Sure. They control the gene expression and they're stable in the blood sputum. So that would be important. And there's certain asthma phenotypes been associated with certain dysregulation of some of the microRNAs. So that then you could get a panel that could be relatively cost-effective to measure maybe 20 of them, to show that certain groups were up or down.
And the exhaled breath can also be used both as a track, so it can also be used as diagnostic, but also can be used as kind of assessment of treatment too. So, yeah.
Did they separate out in any of the studies aspirin-sensitive asthmatics to see if they had a different chemical profile than just the Th2, non-Th2?
Not that I saw specifically, but yeah. So that would definitely be an interesting phenotype to see what, at least experimentally, what these kind of agents do to them. Whether TSLP has a role here or the other kind of interleukins, but yeah, certainly. But no, they didn't specifically look at that.
That wasn't an exclusion criteria for the studies or anything?
Well, not necessarily, no. Yeah.
Save some of these questions. Param Nair, who's been here before, who's a fantastic speaker and a character to boot, is coming. He's sort of the world expert on sputum eosinophilia and using it essentially as a day-to-day test, as you might do with CDC or something.
I tried to get that yesterday. I didn't call.
I forget the day that he's coming. Anybody remember? It's maybe a month or 6 weeks from now.
Anything else?
Good.
Pretty soon that's going to be nice if they could strategize better.
Oh, that's not true.
And that's true.
I'm going to be up. Just call me.
Yeah, you need a lot of technical IL-33 block it out.
IL-33.
Did they compare that because they did a genome-wide screening. It's really just one of the few genes.
Another